Hello, everyone. This is Mark Creekmore. I'm in charge of advocacy at NAMI, Washtenaw County, and this is the first issue of the Advocacy Update, a new presentation to provide information about advocacy topics. This is the first issue in January of 2022, so I'm going to share my screen and we'll begin. There we go. This advocacy update concerns the 988 crisis call centers and the new mental health. January 2022, there's my email address if you care to get in touch with me. And let me talk to you a little bit about what advocacy updates are. They are a single topic presentation in variable video and audio formats. Unlike the Advocacy Digest, which is written email and delivered monthly, advocacy topics will be delivered as needed. The goals are to provide updates on specific and important mental health topics through easily accessible videos or podcasts. And the audience essentially is the same as the digest. NAMI staff, volunteers, participants, and other collaborators who need to know and need to advocate. The structure is very simple. We're going to talk about the history of the topic, the ideas, and how we can take action. This presentation will answer 6 questions. Why 988 is the historic next step in mental health services? What is the political context for 988? What are the 988 goals and potentials? What's the ideal 988 system, and why do we need to advocate for it? And then lastly, how you can get involved. The point of the presentation here is that 988 is the latest step in a historic development of mental health services. And it's a really big step that we're undertaking and will actually take probably years to complete. The first period of mental health services was the what we call the asylum period. Institutional services were provided in Michigan. It began in 1859 with the Kalamazoo Hospital, and it ended, for our purposes, around the 1980s with the dissolution of the mental health institutions to provide mental health services. There are still some available, but they're not nearly as predominant as they were during this period. The focus of these institutions was protection of the public and the protection of people with mental health conditions, and through the quarantine of what they called mental defects. These were this was part of the period when eugenics was a very serious concern, and people were essentially isolated from normal society for fear either of contamination or of dyseugenic existence or a multiplication of mental health defects. So as a result, their sterilization, forced sterilization, was very common during this period. The second period is the community mental health period for serious mental illness, chronic conditions, serious emotional disturbances, intellectual and developmental disabilities, and substance use disorders from the 1970s until now. The focus of that period was the right to treatment in the least restrictive environment. And then coming out of the institutions, you can see how the institutions guaranteed some degree of protection from both society and the people with mental health conditions. And but they did this at the cost of the freedom of people to engage in normal society. So the consequence was there was a right to treatment, which the institutions did not provide really, and there was that was done without necessary sacrifice of individual freedom. So it was a civil rights issue. The third period, which we're currently emerging into, is I call the parity period. And the focus of that is on equitable treatment, both of physical and mental health services, that both should be provided at equal levels to everyone in the society. And that this is in itself a social good, that it will produce socially beneficial results. There is bipartisan support from this, from beginning with several legislative acts. We commonly look to 2008 as the start for this, from the Mental Health Parity and Addiction Equity Act by Senators Domenici and Wellstone. The second example is that this was amended in 2010 by the Affordable Care Act, which specifically said that mental health conditions should be treated the same, given the same level of treatment as physical health conditions. And then there was, on top of that, the Senator Stabenow's Excellence in Mental Health and Addiction Treatment Act, which created the certified community behavioral health centers, which are just now unfolding in our state, providing mental health treatment to anyone, regardless of payer or of seriousness. In 2020, there was a National Suicide Hotline Designation Act, which was the beginning of the 988 number, similar to 911, where anyone can call who is in crisis and receive some kind of assistance. Finally, a step in that, I don't know if you can see that because of the screen share thing, the Department of Labor, Health and Human Services, and Treasury have just, in January of this year, 2022, presented a report to Congress showing that the Parity Act, parity provisions that have been in existence for about 14 years are not being enforced. The legislation is not being enforced. It's a very scathing report, and we can expect to see some changes from that. Here are the current trends for this new parity community mental health system. That mental health services should be accessible to all, regardless of payer or seriousness, as a social good. The second principle is that it will integrate services across all sectors, that there should be no wrong door for entering. So if you come in through the health sector, you will get some mental health care. If you come in through the justice sector, you'll get some mental health care. And that care will be equivalent across all these sectors. And thirdly, we're going to focus on mental health as an informed leadership. The principle is that mental health should have informed leadership across all sectors. So what is the political context for 988 and the Parity Act? Well, first of all, we have a federal system, as you all know from your civics classes, that the federal, state, and local governments share the responsibilities for things like mental health care. No one unit can tell the other unit what to do. They can provide incentives and funding, but it's up to the states and the local communities to develop those services. So federal law requires state and local implementation. That's a very important consequence for our advocacy activities. The second important political context is that mental health services are provided in 6 basic sectors. That the mental health sector is not the largest provider of mental health services. That is provided through the health sector and through primary care. Doctors and clinics prescribe about 70% of the psychotropic medications to people who are receiving them, without the necessarily engagement with the mental health sector like community mental health. So the health sector. Of course, there's the mental health sector, which we know is community mental health, the university centers for mental health services, and inpatient units in hospitals. There is the justice sector, which includes police, courts, jails, and prison, which also provides mental health care at a very high level. Because a large percentage of the people engaged in the justice system now have mental health conditions. Their education sector, primary, secondary, and post-secondary institutions, schools provide mental health services, and some basic services, bureaucracies, and like housing bureaucracies and um, county tax offices provide some mental health services for specific reasons. We can go into that later, but that basic services organizations also provide mental health services. And last are the community organizations. I don't know if you can see that. That's number F is community organizations, which are provided by community grassroots community organizations like churches and NAMI. So those are the 6 sectors which provide mental health services. Let's talk a little bit about crisis call centers on the calendar. The crisis call centers were founded 10 years ago with the Emergency Services National Suicide Prevention Lifeline. That was provided through a model of development which allowed people to call one number nationally and receive suicide prevention services. The success also is comes from the 911 emergency services, the fire, police, and EMT, which have also received a large number of crisis calls, but they're not really designed, the emergency services are not really designed for crisis behavioral mental health crisis calls. So that's why they have developed 988, because of the influx of a large number of calls that are really unsuitable for fire, police, and EMT hospital treatment. This service will begin in July of 2022. The marketing rollout is said to begin in January 2023, and it's going to require collaboration between funding structure and standards in state, federal, and local organizations. The goals for 988 are to decrease the inappropriate use of the justice sector, especially jail and prison, for mental health crises, to decrease the inappropriate use of the health sector, emergency services, and inpatient beds at hospitals, because crises do not often need to go to emergency departments or into inpatient beds at hospitals, to decrease the level of suicide and completion in society, and to expand service access for mild to moderate and substance use disorder crises, or for any behavioral crisis, regardless of funding statewide. So those are the goals of the 988 system. Primarily, however, it's to avoid the inappropriate use of justice and health sectors to deal with crises. The potential for 988, we identify 4 areas to prevent some serious mental health conditions. That is, if you treat a crisis upstream before it becomes a serious or chronic condition, you can prevent that becoming a more expensive problem and a more damaging problem. The second is to expand the current mental health system from a safety net to a system that is accessible to all. Right now, CMH is primarily service to people with chronic and serious mental illness, and cannot really serve the people with mild to moderate problems. The third reason potential for 988 is to normalize services and reduce stigma. This has long been a goal because stigma prevents the appropriate treatment of mental health services. And if more people get treatment and it's normalized through a crisis call line, it can decrease the stigma for getting help soon. And finally, it has the possibility of building sustainable support for mental health services through demand from the bottom up, that is, from people who are in crisis and need help. So that's the potential for 988. Here's how the 988 ideal system would work. Starting over on the left with the person in crisis, that person would call the crisis line, or the crisis line could be notified of a call from the 911 system. 80% of, it's been found through the Suicide Prevention Lifeline that 80% of the calls can be resolved on the telephone and stabilized. The 20% of those calls which cannot be, there will be a mobile crisis team which can go out to a crisis situation. And that can be also identified through police to actually engage the mobile crisis team if they find it's useful and necessary. Because police, as you know, are not really trained to provide mental health services. And so the mobile crisis team will provide services in conjunction with them. 70% of those cases have been resolved in the field. The remaining 30% of those remaining can be sent to a crisis facility, which also can be sent to by a police officer. And 60% of those people who come to the crisis facility for a longer term assistance, face-to-face assistance, can be discharged to the community. Of course, then there can be post-crisis wraparound services and crisis residential and respite services for the remaining people to stabilize them. And again, the goals are to decrease the use of jail, decrease the use of emergency rooms and EMTs, and free up hospital beds. This has been especially important during COVID when we've seen those services and resources severely taxed. What is the system, the new 988 system, dependent upon? Because it's never preordained that these systems will work. What are the threats? First of all, we can slow walk this system and just exhaust it by a slow implementation. The system also can overreach and promise services that it cannot actually provide. That's a threat to its credibility. It can continue the inequity of the distribution of services, especially to poor and minority communities, which now do not receive as much equitable mental health services as the other people in the society. It can be poorly implemented, and that can reduce its credibility. And there can be obstruction from self-interest and professional protection of service fields and the like. There are also unanticipated consequences. And one of the ones that we are concerned with in NAMI is that the expansion of services to the mild to moderate will threaten the existing safety net services to the chronic and serious conditions, treating the chronic and serious conditions in mental health. So those are some of the contingencies for the 988 system. Why do we need advocacy? Well, advocacy can build reasonable community expectations and help provide funds for those services. It's going to take time for these services to develop, and we need community participation in this, and we need to advocate for the 988 system to show people what the reasonable expectations are and how we need it to be funded. We need to expand workforces through better pay, more peer specialists, and revised scopes of service, and advocacy can help that. There simply are not enough people to provide mental health services, and we need to restructure our mental health system to allow for more flexibility for mental health services. The third advocacy need is to support community collaboration, especially between the sectors, the mental health sectors, justice, education, and health sectors. Those sectors that we identified before need to really work together and collaborate. And we can advocate for that. And finally, and one of the most important, but often neglected, is the importance of a rigorous recording and evaluation system for mental health, the 988 system, to show that it does work and to improve and improve the quality of services when it's not working as well as it could. So those are the reasons we need to advocate. Here are ways you can get involved in our advocacy leadership. You can respond, question, and challenge this presentation and help develop consensus among us. We don't claim to have everything right, and we're interested in people who have a critical kind of view of why we're doing it and what it's trying to accomplish. You can register to get the Advocacy Digest through this very shortened email. You can also write us, send me an email, and I'll sign you up for that link. You can attend advocacy meetings. We have meetings every week at Tuesday at 5 p.m. And these are Zoom meetings, and then a leadership team on the first and third Thursdays of every month, also at 5 p.m. You can share this advocacy update with others and get them involved, and send us your ideas about what you want to hear with future advocacy updates. Email us with your ideas for future sessions and your questions and concerns. And you can also go to a site which will answer frequently asked questions about 988. If you need any of these repeated, I'll be happy to send them an email. Just give me a ring. That's it for the NAMI advocacy update. Thanks for listening, and I hope you enjoyed it, and will give us a ring and help us keep in touch with you. Thanks very much. Mark Creekmore signing off to Advocacy Land. Talk to you later in future updates.